Okay, well, welcome to the second lecture of the ASAM Criteria and the Future of Care. With that, I'm going to do that quick review that I chatted about so that everybody's at least on the same basic page as we go. So let's get to, now remember we talked about last time that we talked about the four major components of care. So medical being one of those, psychoeducation being another, psychotherapy being separate but Venn diagram related to psychoeducation, and then the therapeutic milieu, which is kind of the all of the other additions that we deliver in care with creating a supportive, consistent, constructive, positive, peer-based environment that we'll talk about. So this is the basic construct for the fourth edition of the criteria, meaning we identify which of these four things people need the most based on dimensional analysis, and then we put them in the level of care that matches which one of these they need the most and at the highest level of ability. Now, if we dig in a little bit more and we just look at medical care, again, remember medical care is not just the prescriber. It includes a physician or a PA or a nurse practitioner, an advanced practice nurse, but also the RNs and LPNs and medical assistants that help us within this space. So that is kind of the totality of all of the medical care that is delivered. And somebody may be doing vital signs and doing intake, assessment informations and then handing that over. And then a nurse may be doing withdrawal management, delivery of medications. And then the prescriber may be ordering those medications and doing other things, but they're all part of kind of the medical line of service in a sense. And our job is to make sure that we take care of medication management, withdrawal management, ID management. And the way to think about that is I always talk about the piece that's important. The way I talk about it is the addiction adjacent illnesses. So these are the things that very commonly occur along with addiction. So that could be liver failure from alcohol use. That could be skin lesions from injection. And that can be HIV and hepatitis C and all sorts of things that we see pretty commonly here. So that's in that. And then being able to do that from a lens of motivational interviewing, which that motivational interviewing very early is very important to get a person solidified in the recognition that it takes a team to get them better. And I really want to make sure that everybody is on board with the reminder this is a team sport. I'm triple boarded doc, done this for 20 years. If I hang my shingle in a clinic, I still only provide this, right? So I can do all of those things, but it's really within this domain because I am not a person trained to deliver psychoeducation. I am not a peer. I am not a, I'm not a therapist. I am not, I'm not someone who has that lived experience to be able to do that. So it takes this entire team to deliver that. And I would be just one part of that. And then if we look at psychoeducation, we spent a little bit of time on this last time, and I'll do it again just to make sure we all feel comfortable with the difference between psychoeducation and psychotherapy. So psychoeducation is typically delivered by a certificate level provider, which means that their training has been in that shorter amount of time and really focused on very practical ways for people to decrease risk of relapse and to keep them in remission and to keep them connected to care. And so it generally should be coming from a standardized curricula, which for us old timers means books and manuals for that. Clearly those things exist on online as well, but we have a number of different things like anger management, seeking safety, relapse prevention, men and women seeking recovery. There are a number of those that we can utilize that when we disperse it out to the entire company, our group of counselors should be able to run groups pretty consistently that deliver that specific information. And if that specific information is delivered without modifying it too much, then the data is pretty clear that for people ready for that, it significantly improves their outcome. But I will tell you that if I try to do it, I do a poor job of doing it to fidelity, meaning I do a poor job of sticking to the script because I want to go down my thing and my scope of practice and I get all tangenty. And honestly, it's the same for master's level therapists. They want to not deliver that at that fidelity, and they want to slide into what they're, well, I was thinking about this through the lens of EMDR, and maybe we could do it. And then it just breaks the model. So we need people to actually deliver it the way that the model is designed. It's typically group based, which is why we've been pushing groups, because it honestly doesn't work as good one-on-one. It works better if delivered in a group modality, because part of what they have to do is learn how to interact with another group of individuals who are in recovery or just the general population, and they don't do that one-on-one. And so they need to be able to learn how to re-interact in that piece. So it is exceptionally important that we do this without getting confused about the other stuff at the same time. But a lot of our patients aren't going to necessarily be ready right out of the gates to do this and onboard all of that knowledge, which is why we have psychotherapy. That is going to be our master's level or higher professionals. And the focus of this is, really digging into the diagnosis, delivering specialty level counseling for what they do. It is almost always individually focused. Sometimes it trickles into group therapeutic models because there are specific therapies that you need a group for. But ultimately, we have identified a maladaptive behavior that cannot be controlled just by onboarding new technical skills. It has to do with the philosophical and emotional frame of that maladaptive behavior. And so we need to get a person to recognize how they see themselves, how other people see them, and then modify their behavior associated with that. That is the core concept of CBT. And so that core concept of CBT becomes really important in our ability to get them ready for psychoeducation. So just plopping somebody into group isn't going to work for everybody. Just putting somebody in psychotherapy, they may be like, I get it. I just need to know how to say no. How do I say no? How do I not get angry? And then that's where the group solidifies that piece in the psychoeducation. So every one of these things has a unique and very specific role in order to deliver comprehensive care. And so this is why it's so important to recognize that there is no such thing as hierarchy, only scope of practice. So the doctor is no more important than the counselor. The therapist is no more important than the doctor or the counselor. Everybody has the thing that they do, and we just have to focus and do that well. And this is how the 4th edition of the criteria is designed, because as we look through the lens of our dimensional analysis, which we'll chat about again in a sec, what we find when we do that is that we're going to have certain dimensions that are driving their risk. And our goal is to put them in the level of care that best suits what their risk is. Some risk may be medical, and if that's the case, we'll put them in a level of care for medical focus. If they need therapy, then we'll put them in a level of care where therapy is the focus. If they need psychoeducation, then they get that level of care. And we'll talk about in a minute which those what those levels are. If we look at the therapeutic milieu or addiction treatment supports, or those can be used interchangeably. And milieu is just harder to spell than supports. And if it wasn't for spell check, I would misspell it about half the time I try to write it. But this is typically going to be delivered by peer support specialists. It's going to be delivered by sponsors if they have self-help modalities that they're utilizing. Other stable clients can do this. So you can get addiction treatment supports that occur in a group when you have people in that group who've been in remission for a year or two, who really can bring kind of an anchor of safety and support into that environment. That's a really important piece to remember, is that clients in early and stable recovery can be very helpful. Not to give advice, that's not their job. It's to show that the work that's being done can get somebody in a very stable life situation, because so many people early in recovery don't feel like it's possible. So having that peer that they can look at who's done it becomes important. Not to tell them what to do again, but to just show them that it can be done, and recognizing that everybody has their unique pathway, to recovery. And depending on what their needs are and their issues are, depends on their path. So this is an important conceptual piece. So if we, this is the reality, right? I think the problem with our clinics right now, or one of the confusing pieces of it, is that this Venn diagram is squished together even more. So there's so much, like, everybody does everything. And so that means nobody does anything really well. So if I'm a doctor and I feel like I need to be delivering some extra therapy, so I'm going to take some extra time, that's not really that helpful, because you know what? We have people who are experts in that who can do that over here. So if you're, someone who really is built for delivering psychoeducation, but you want to do kind of therapy, we have other people who do that better, and they don't do your job better. And so it's important to make sure that we stay in our lanes, not because of any hierarchy, but because if we don't, then patients are not getting the benefit of us doing our job well. And that's the reason that we want to have this Venn diagram overlap, but not overlap so much that the patient doesn't really get what they need from the people who are specialty trained to be able to deliver that. So how does the fourth edition handle this? I talked quickly about, we've moved away from an expert opinion. I'm going to skip through the slides of all of the data used to get there, but it's, again, important. This was not just done willy-nilly. This was 2.5 years of basically deep methodological science, and thousands of hours and hundreds of meetings. We wanted to make sure we understood the dimensional analysis in a way that was more practical, make sure that withdrawal management sits inside of normal levels of care, better define outpatient care. We did talk about how our ASAM criteria for jails and prisons is going to sit in a different volume, and the adolescents will sit in a different volume. The jails and prisons will come out in January, and the adolescent ASAM criteria will be out next fall. And then risk ratings and level of care determination were combined. These were separate in the past, and I don't know if I discussed this last time, but what happened was the risk ratings were oversimplified. So that's what the payers would use. The payers would say, well, I'm just going to use the risk rating, and it would disagree with the level of care determination many times. And so that's where we got into utilization management fights of, does somebody need to be here or there? So we've combined those so that those fights don't occur, well, as often. This is just kind of the development process. We talked about the public, piece. And then just to remind everybody, we've modified the dimensions. And again, can anybody remind me what I called the first 3 dimensions?
Death dimensions.
Yes, the death dimensions. They're the death dimensions because if you miss something in those first 3 dimensions, it can kill you fast. And so it's really important for us to recognize that if we get into dimension 1 and 2, we may not have to pass go at that point. It may just be 911 hospital. Like, we don't have to do a whole deep dive piece. But this is also why we're modifying our initial intake process to be kind of medication first and fast, because we need to have a deep dive focus on those first 3 so that we make sure our patients can come back to us the next week. It's a really important piece. And then 4 and 5, in the new way, look at the risk of relapse, meaning how likely are they to say yes if somebody offers them drugs, is the simple way to think about it. More complicated than that, but generally that's it. And then the recovery environment interactions, which is how is their living situation, and not just do they have a roof, but can they be functional in that roof without causing chaos? And those are the main pieces. And then the new dimension 6, which is person-centered considerations. So the first 5 determine what level of care they should go to. Dimension 6 helps us to determine which level of care they're willing to go to or is available for them. And that's what dimension 6 is for. The other thing that sits in there is the social determinants of health. So transportation, ability, and money, and job, all of those things that impact our patients' ability to come and see us on a regular basis. All right, so that should really kind of review what we talked about last time. We spent a lot more time digging into that stuff on the last one, but I think that catches everybody up. We had gone through this in the next slide, but I'm going to start here and deep dive on this one again, because this is you're going to spend a lot of time doing in the dimensions. This is where you're going to spend most of your time on the treatment plan development and working with a patient. And so you should know these dimensions backwards and forwards. So I would rather know dimensions and not have a freaking idea about the level of care than know all the levels of care and how they get staffed and what they do, but not know the dimensions, because the dimensions are what change the outcome of the patient. Meaning, if they have a significant issue with dimension 3, we should be laser focused as a treatment provider on modifying the outcomes of dimension 3. Right? The other ones can matter, but we need to focus on dimension 3. And this is how you would have your plan meeting in the morning with your other providers. Like the doc may be like, well, I need to see him first. And then the answer is, well, in the treatment plan, dimension 3 is their most significant thing. So unless you're going to be writing them a psychopharmacological medication, then what they really need to see is the therapist today first. We need to make sure that we're digging in on this piece. And this is an alignment space where we can all agree to the same outcome of recognizing this is the most important thing. The most important thing is that we push on dimension 3. Now, once we stabilize that, then we decide what the next dimension is that we should be working on. And whether that's a 4 or 5 or SDOH dimension 6, it helps us focus that. It helps us create a language of what is your role. So if you are a counselor and people say, what is your focus on patient care? Your answer is dimension 4, 5, and 6. That's the wheelhouse of a counselor. If you're a targeted case manager, your focus is 6. That's it. I want you to dig in. I want you to know everything about that and understand and how to modify it and how to fix those things. If you are a therapist, it is dimension 3 first, followed by 4 and 5. If you are a prescriber, it is dimension 1, dimension 1, dimension 1, then dimension 2. I want you to make sure that we have focused on those dimension 1 issues, because if we don't identify the substances that they're withdrawing from or could be intoxicated on or overdose on, then we have a real problem. Withdrawal is really important, but the addiction medication needs are important. So we're really good at starting people on buprenorphine and methadone, aren't we? That's what we do pretty well. We're pretty crappy at writing people medication for alcohol use disorder. We're not very good at helping people with nicotine and tobacco use disorder. We're not really helping them with some of the other sleep disorders associated with that. So addiction medication needs is more than bupe or methadone or naltrexone. It's more than that. So we will be pushing hard on those pieces, but we get so distracted by some of the other stuff that we forget to just do a comprehensive thing, which is why I want you to own your dimension. Like, you need to own it. You need to teach me about how these dimensions should be evaluated. If I say, how's your patient? You should say, well, right now we're focused on dimension 4, and within the pieces of dimension 4, we're working on this, this, and this. If you start thinking in the dimensional driver mindset, then what you're going to be able to do is reflect that in your treatment plan. Because right now, when we review a bunch of treatment plans, what we see is a whole bunch of things that need to get done without anything in any order of operations. Like, well, what has to go first? Right? So we use ABCs in a code: airway, breathing, circulation. Our ABCs are dimensions, and it depends on which dimension we need to get to. And this is the same way. Dimension 1 through 6 is the order of risk, but it doesn't mean that's the thing we focus on. If we've stabilized 1 and 2, then we're on to 3. If we've stabilized that, let's dig into 4. It doesn't mean some of these things can't happen in parallel, but different people are focused on different parts of this. Does that make sense to everybody? So I want you in your brain to say, with my certificate or my degree or my training, my focus is, and know internally what that is. And make sure that if you don't feel like you are adequately trained, supported, capable, knowledgeable to do these things, that you raise your hand and be like, hey, you need to teach me how to do this because I didn't learn that and I need to know how to do that. And you know what we will do? We will teach you and we will support you and we will make sure that you get those pieces, because it is really important that you have all the tools in the toolbox, in the tool shed. So this is about, if you need to know that dimension, dig in. And if you need something from us, let us know, and then we'll make sure and get it to you. That's why we've developed, basically divisions of education under each umbrella. Christina Garlib is your director of clinical education, and she's going to be working with a number of other clinical educators to put together the full curricula that'll be both online and in person to maintain that. And so if you have an issue, you have a question, you need to get better at something for your patient, let us know, and we'll work really hard to make sure that that happens. All right, so we've talked about the dimensions. The term that you'll hear me say a lot is dimensional driver, and that's how I would ask, what's the most important dimension right now? I would say, what is this person's main dimensional driver? And you'll tell me. From your point of view, it could be dimension 4. And then from the medical person, it could be dimension 2. And so as a team, we would figure out which of those ends up being more important. Because dimension 2 may be chronic medical illness, nothing really acute that we're going to have to fix right now. So it's important, but it's not as important as their trauma-related needs in dimension 3. And so we would really focus down on dimension 3. So we'll get, everybody's going to get this training. You're not going to be the only ones that has this. All the medical providers are going to get this. Everybody's going to get this. So we'll all be speaking that same language. This includes operations. This includes, this is going to be the language of how we speak about the people that we're treating and the levels of care that we are. Any questions about the dimensions before I move to the next slide? So by the way, ask questions as we go, because we're going to, I'll be recording this for the online version so that you'll always be able to go back and watch not only the one we're recording now, but I'm going to record specific ones with some different graphics and stuff to make it easier. So if you have questions, don't worry about interrupting. Perfectly fine. So I'll give you a sec. Anybody? Bueller?
I just had a quick question.
Yeah.
In regard to the counselors, dimension 3, 4, 5, but not 6?
Well, in a perfect world, dimension 6 should be case management. So we should have our targeted case managers and care managers and case managers, depending on the state, depends on how we talk about them. Now, if we're fully staffed, then I would let dimension 6 sit in the world of the TCMs or the care managers, and you focus on your dimensions. If, however, you're in a clinic that's not fully staffed yet, and we haven't gotten the people hired to come in and do that, then yeah, I'll add one more. That's the dimension also you would be focusing on. It's a good question. But at the end, for treatment, I really want the counselors to be focusing mainly on 4 and 5, therapists to be focusing on 3, 4, and 5, and then for care managers or case managers to be focusing on 6. Again, there's a Venn diagram of these things, and that Venn diagram will depend on staffing levels, patient needs, and stuff like that. That's a great question.
Thank you.
Mm-hmm. Anything else? All right. Next slide. All right. So last time we didn't spend much time on this because it's hard to read, and it's still hard to read, and you don't have to read it. But I am going to spend more time talking through what this means. And if we talk about the dimensional admission criteria, each dimension, we've come up with a number of components of that dimension, and you saw that on this slide. The things in blue are the primary components of a dimension, and then the things in black are secondary components of that dimension. And the ones in blue are the ones that directly determine level of care, right? So the fact that you've had early life trauma is really important in dimension 3, but it's not going to necessarily determine level of care. Does that make sense? Level of care is going to be determined on your psychiatric symptoms that are active right now, and if I need to get you to a higher level of care because of those active symptoms. If you have persistent disability because of your generalized anxiety disorder, depressive disorder, or psychotic disorder, that will determine level of care. But your cognitive functioning will take care of that in whatever level of care that you need to go to. If you have trauma, it doesn't matter which level of care you're in, we'll modify our treatment plan to focus on that trauma, but it's not going to change whether you need residential or outpatient. And so the psychiatric and cognitive history as we're going through somebody's lifetime, whether they had a traumatic brain injury, a learning disability, if they've been diagnosed with everything in the DSM-5, which many of our patients show up with that laundry list of incorrectly diagnosed ailments. And those are there, but it's not, unless they're actively symptomatic with it, it's not going to change their level of care. That makes sense? So when we say dimensional admission criteria, that means that for everything here that's in blue, we have determined a set of rules or if-then statements. So if we say ability to function effectively in current environment, if the first answer is no, then that means if this answer is no, then we need to determine severity. Is it a severe dysfunction? If yes, then that goes up to 3. If no, then it may just be IOP or recovery residency. So it's everything here has an if then statement. Is this an issue? Yes or no. If it is, then we go to there. So if we look at this, this is the layout of the if then statements for the 0.7s or the medical levels of care. Remember, we talked about the 4 components. If somebody comes in and their main concern is dimension 1, 2, or psychosis or suicidal ideation, those would be the ones in 3 that put them into a 0.7. Then we would start at the top. Patient has an active SUD, yes or no? If yes, then we go down. Does the patient need level 4 for dimension 1 or for dimension 2? And again, level 4 is a hospital. If the answer is yes, then they go to the hospital and we're done. That's our intake. Thank you for, showing up, and we're going to now put you in a car and get you to the hospital where you should go. We're not going to flog them while they're throwing up all over the floor and having arrhythmias, right? We're going to fast track them to the hospital. So if they don't need to go to a hospital, then do they need level 4 for dimension 3 only? And that means, do they have active suicidal ideation with intent and plan, or are they actively psychotic? If so, then it's either a hospital or a psych hospital. And that's a level 4 pathway for co-occurring. And then we just keep walking down the list. If the answer is no, does the patient need medically managed care? If the answer is yes, then we go into the rest of this thing. And medically managed level of care are the 0.7s. So if we go to here and we go all the way to the right, these are the medically managed levels of care. And so for hospital is defined very specifically as a place where they can put a tube in to breathe for you and shove you in the ICU. It is no longer just a psychiatric hospital is no longer considered a hospital in the new criteria, right? So if you need a hospital, then you go to a hospital, like an emergency department, where you'll see a grumpy ER doctor like me, and we will do those medical funny things for you for needles and tubes and all of those things. If, however, you don't need a hospital, you may need residential withdrawal management. You'll notice that for 3.7, this is medically managed residential. In the 3rd edition, it was medically managed inpatient, which was really confusing because they're like, inpatient? Isn't inpatient a hospital? And the answer is, yeah, kinda, depends. So it was confusing. So we removed inpatient and also hospitalization. And so that's why you don't see PHP anymore. We see, as we look here, you have medically managed inpatient, hospital, medically managed residential, withdrawal management / detox unit, 3.7, 2.7. This is where we get into the game here. So our comprehensive opioid treatment programs with nursing are medically managed intensive outpatient capability, because we can see them daily. We can titrate their medications if we need to. We can handle somebody who needs to show up every single day if we schedule them that way. And we can give them medication on site. That's an important component of that. And then 1.7 are medically managed outpatient, and that would be our OBOTs. This is the place where we have to prescribe medication for them. So we would see them. They're safe for us to be able to prescribe medication and send them out. And then so 1.7 is where our OBOTs would be. So what's the difference between a 3.7 and a 2.7? Well, the only difference between those is that a 3.7 has overnight monitoring. A 2.7 has all the same scopes of practice, as doctors and PAs and NPs and nurses and MAs, all those medical people that we talked about there. It still has all those same people. It's just delivered in an outpatient setting. So what would be different for somebody going to 3.7 or 2.7 if we have everything in the outpatient setting? It's that if they are unsafe to be at home at night, either because they need extra monitoring, like their vital signs, or their risk of relapse is so high that we can't send them home, then a residential treatment is the place where we would want to go. Does that make sense? Only difference between a 3.7 and a 2.7, overnight monitoring. What's the difference between a 1.7 and a 2.7? That's actually a bunch, because you don't need nursing or therapists or anything at a 1.7. You need to have a contract with a provider for psychiatric care, not psychiatric, sorry, behavioral care. So psychoeducation, psychotherapy. in order to be a 1.7. So me, as a board certified doc, I can go hang a shingle and I can be a 1.7, but only if I have a contract to send people to a behavioral therapist as a part of my care. So I can't just do what I do. Now I can still go do that, but I just wouldn't be a 1.7. I would just be a doctor who does the thing that a doctor does. Does that make sense? 2.7 adds a nurse and adds the ability to see them daily and titrate things, and has after hours call capability, which, by the way, we're about to implement a system-wide after hours call capability for all of our states. We're finishing up what that looks like and how we do it. But any questions about the 0.7s?
Dr. Waller, I do have some, I just need a little clarification, I
Yep.
think, on the 1.7 to 2.7. So what I'm kind of hearing is most of our patients, or probably a lot of them, when they come in, are going to be more the 2.7 for us, because they do need to kind of be observed as their dose, or as they're doing the withdrawal management, getting their doses, things like that. But the 1.7, I guess I'm a little unclear on what that means.
Yeah, so the 1.7, the way to think about it is kind of a primary care office in a sense. Like, you don't have a lot of sophisticated equipment. You don't really have the ability, you don't have nursing care to deliver withdrawal management. You're just kind of a doc in the box. And what we said is that in some communities, you know what, that's okay. If you're a board certified addiction psychiatrist or addiction doc and you want to deliver care to people and you don't want to have to do it in an opioid treatment program or an FQHC, that's fine. Like, I don't want to tell people how they have to work, because you're still a super knowledgeable human being in addiction and you should be able to do it. But you can only be a 1.7 if you've contractually connected with somebody to deliver behavioral health care. So that means you have to have a working contract of sharing information and referring patients back and forth. Not just a, hey, I know somebody in the community I can bounce them over to, but you have to have an actual contract and a data sharing agreement with them. So none of our sites are low-level 1.7s. In fact, most of our sites, the only two things our OBOTs that we would need to be a 2.7 is making sure that we have a nurse. Now in Ohio, that's not a problem. Generally, we have an LPN at all of our even OBOTs there. What we need to be able to deliver are medications. Now, we don't specify if it's buprenorphine or methadone. So if we have the ability to titrate medications and do this, we can actually fill their meds on day one, meaning we call the pharmacy, we dispatch somebody, or the pharmacy brings it to the clinic, and then we help titrate that on day one. Then that place can be a 2.7 as well. Like, you don't have to be an OTP to be a 2.7. It's all about what intensity of care can you deliver at that site. Because I don't need a controlled substance to treat alcohol withdrawal. So we can, if I have a nurse and the ability to do the other evaluation pieces, then I can do that. So a 2.7, the way to think about a 2.7 is our fully staffed OTP is an easy 2.7. Now, if you look at it, if you're a 2.7, then you have everybody you need to be a 2.5 or a 2.1, or a 1.7 or a 1.5. Meaning, if we decide that this person is stable from their medical care and they no longer need a 0.7 because we've titrated, they're on a stable dose of medication, now we look at these other levels of care. And a 0.5, if we look at the four things that a person needs, a person who has issues in dimension 3, 4, and 5, who needs psychotherapy, will go to a 0.5. 0.5 is where psychotherapy lives. That's where the focus of that care is, master's level assessment, psychotherapy, direct one-on-one, lots of interaction there. But you still have to have the ability for them to get all their medications and to have access to a medical provider. They just don't have to be on site if you're just a 2.5. So if you're a 2.5, we changed that from PHP to high intensity outpatient, and that's 20 or more hours per week. What's interesting is that we can deliver high intensity outpatient at a lot of our clinics because we're open plenty of hours a week to do that. We just haven't really put together a curriculum to be able to deliver that, because most of our clinics don't have a big enough population to be able to deliver that at scale. So that 20 hours is a combination of case management, therapy, psychoeducation, addiction treatment milieu, medical intervention. So it's 20 hours of all of that together, which would equal high intensity outpatient. And then if they meet for 2.1, what do you guys think if a 0.7, if the focus of a 0.7 is medical and a focus of a 0.5 is psychotherapy, what do you think the focus of a 0.1 is?
Psychoeducation.
Right, psychoeducation. So this is a really important piece because it lets you know the minute you see which level of care they determine, it also tells you what they should be getting. So you do these dimensional admission criteria, you go through it, you determine which level of care they need to be in. And if you see that their level of care is at 2.1, now you know what their focus of care needs to be. And what does it need to be? Psychoeducation. And so now we know which providers they should be seeing and getting that standardized curricula, that's a kind of manualized, standardized curricula across all of those. If we complete the dimensional admission criteria and we see that this person needs a 0.7, no matter which one it is, they need medical. And that's going to be the focus. And we should just be like, oh, okay, looks like you need medical first. Let's get that done. And if you need 0.5, oh, let's get you in to see our therapist so that we can make sure and tidy up the assessment stuff that we need and do any of that individualized stability therapy that we need to now and shore up that suicidal ideation or issues that we're identifying. Does that make sense? So when we talk about dimensions, that's when we start talking about the dimensional drivers. So I'm gonna go to that first and look here. So if we look at the 0.7, you can see here about 70% of that is medical. It doesn't mean we're not also doing some psychotherapy and psychoeducation. It just means that the focus of that level of care is going to be medical. Psychotherapy, meaning building a treatment plan, evaluating what we need to do, and then psychoeducation, putting them in anger management groups, just some, getting them back into some people around them groups, so that they can start to reintegrate. Those are all things that we want to be able to have happen. Now, if we go to 0.5, again, the focus of a 0.5 is going to be psychotherapy. Most of what they're getting is one-on-one psychotherapy, EMDR, DBT, trauma-based CBT, very specific modalities. And you can see up here, their dimensional drivers are what? 3 and 4. 3 and 4 are the major dimensional drivers for needing a 0.5. And so if we say that this person has a significant dimension 4 issues and are pretty unstable in dimension 4, then that would push them to a 0.5. If they're just mild dimension 4 stuff, then that could be a 0.1. And then if we go into 0.1, mostly psychoeducation. So this is mostly group-based psychoeducation that's being done. We're updating treatment plans. We're still leaning in, as you see there, the treatment milieu, which means we're doing a ton of working on their social determinants of health, looking at all of the other issues that may need to be handled with their home, with transportation, with getting a job, doing those things. But half of their time spent with us is going to be sitting in a group or getting some one-on-one psychoeducation if that's one of the pathways that we think is best for them. And then I'll still, though, medical, they're still going to touch base with medical when they come in. And that could very well be hey, I don't need to see them, so I'll just go ahead and do a bridge dose for them, which, by the way, we're going to have a specific note for that coming. So that way, everybody will be co-scheduled with a medical visit when they're scheduled for clinical so that they show up. And they won't necessarily have to see the doc. If the doc doesn't feel like they have medical issues, we can just release them with no charge. But at the same time, it brings them to the place where we can intervene with them. So we're going to be working on those pieces, because that little 5% sliver, while not the thing that we need to focus on for the patient, is many times the thing the patient is still focused on. Like they're still focused on, I need the med, I need the med, I need the med, but I don't want to talk about my mommy issues, right? So they're going to come in to get the med. And what we want to do is pivot them to group or pivot them to psychotherapy if that's what they need based on their treatment plan. And then the other levels that we talked about, level 1, which is pretty whatever they need. So this is a person who's been in long-term remission, greater than a year, stable in their disease. They would pop in and see us, as often as they need to. If they have meds, they need to see us at least every 90 days. If they are not on meds, they can pop in as often as they need to, but we would give them whatever they needed when they showed up, because we don't know. Do a recovery capital evaluation, make sure that things are going well. And then recovery residency, which is different than residential treatment, meaning there are no licensed providers in a recovery residency, but the treatment, addiction recovery supports, or the addiction treatment milieu is heavy there. How do you talk to people? How do you interact with people? Even basic things like remembering how to do laundry, how to like plan your calendar, how to get a credit score and a bank account, like some of these things that you need just to reintegrate back into society, because many of our patients have become so broken over time that they've lost the ability to do those things. So that's, for those that need that, they would meet criteria for recovery residency.